Hi everyone. So I'm going to talk about some pathology, certain rare pathology in pediatric cervical spine through some cases. So you should have some thought process when you're dealing with the cervical spine pathology in pediatric. So you'll consider, a combustion site, type of pathology, bone quality, neurology of the patient, stability, and age. So all this factor, you need to keep it in your mind when you're planning for any treatment for pediatric cervical pathology. And you need to define what's your goal, because as you know, pediatrics are growing spine, so you need to have plan on long term, and for each patient unique. If they have, underlying disease, connective tissue disorder, or tumor, so we will have different modality of treatment. So I'm going to present through a few cases. So the first one, 11-year-old female with 1-year history of neck pain and 2 weeks history of worsening pain and left hand weakness and numbness. Her exam, weak left hand intrinsic, and the rest is normal. So you can see in her X-ray, So in the X-ray, you can see T1 is totally collapsed with some focal kyphosis, and also there's asymmetry, some sclerotic deformity on the cervical spine. And this is her CT scans, and you can see T1 completely collapsed. Even there's some destruction on the posterior aspect of the lamina, and also the facet joint extend to the TB of the T1. With the pointer. Yeah, okay. So you can see that, the destruction. On the MRI, same thing you can see. So there's destruction and total collapse of T1. There's some fluid levels on the bony lesion at the transverse process, and also at the spinous process of the lamina. So there's compression both anterior and posterior. And also if you look on the oblique coronal view, you can see there's some tumor or mass extending to the lower trunk of the brachial plexus. So you're dealing with 360 pathology, and the spinal cord compressed at the center. So for this kind of pathology, she's still a child, so there's compression anterior and posterior, and most likely based on imaging, you're dealing with ABC. So surgical planning for this patient. So we start at the beginning with the anterior. So we did standard approach for anterior, then total resection. So the T1 totally collapsed. So resection of the tumor, extending way lateral till take all the residual from the left side. And after that, flip posterior instrumentation and fusion. The other thing important, during the surgery, so you can see the nerve root, the extended nerve root, this is on the left side. And also you will be able to see the cage ventrally, so you make sure all the tumor is resected completely. The other interesting point in this case, if you look her X-ray preoperative, so there's some sclerotic deformity. So putting one screw supporting to correct her deformity, that will help to achieve her correction and tumor resection. Another case, this is 23 months, female with a neck pain, multiple fall. Exam myelopathic with cuffulous, but she's able to walk, but with multiple fall. Her X-ray, you can see there is cervical kyphosis with dystrophic type of deformity on her spine. And the other important thing in her image, you can see the C1 is sublux anterior. There's no really good bone quality to do instrumentation, but on the MRI, you can see there is signal change in the spinal cord, and it's dynamic, so not ingoing compression. So given her age, she's 23 months with the neurofibromatosis type 1, her bone not completely developed. So you need to have special treatment plan for this patient. Giving the consideration her C1 subluxation anteriorly. So using the hooks construct, so all hooks, and you need to have some clear plan, because you need to compress and distract, and that will help to achieve and restore her cervical alignment. And this is her almost 1 year post-operative. Another interesting case, this is 4-year-old female with 2 weeks post-MVA. She's transferred from other hospital in cervical collar, femur fracture, exam intact. And there's some